Hi everybody, and welcome to our module on antidepressants. Antidepressants are generally broken down into 5 groups of drugs. The oldest antidepressants are the tricyclics and the MAO inhibitors. The groups that are most commonly used today are the SSRIs and SNRIs, and then there are a small number of atypical antidepressants, and we'll go through all of these in this video now. Before we begin discussing specific antidepressants, let's talk about some general principles of the treatment of depression. Depression is associated with certain changes in CNS neurotransmitter levels. Specifically, low serotonin, low norepinephrine, and low dopamine activity are all common in patients with depression, and symptoms often improve if you can boost the CNS levels of these neurotransmitters. And so that's how most antidepressant drugs work. They either block the reuptake of these neurotransmitters, so the levels in the synaptic cleft are higher, or they inhibit the breakdown of these neurotransmitters. Just so you have a clear picture in your mind, this is how synapses work in the central nervous system. A neurotransmitter is released from a presynaptic neuron, and that neurotransmitter can bind to a receptor on the postsynaptic neuron. Some of the neurotransmitter will be broken down, other neurotransmitter molecules are taken back up by the presynaptic neuron. So the 2 ways that most antidepressants work are either by blocking reuptake or inhibiting the breakdown. Many central nervous system neurotransmitters have a chemical structure called a monoamine. For example, if you look at serotonin, whose chemical name is 5-hydroxytryptamine, you can see that it has this NH2 group here. That's an amine group, and there's only one of those groups, so therefore serotonin is a monoamine. And histamine is also a monoamine, so is norepinephrine, and so is dopamine. So because all these neurotransmitters are monoamines, many drugs affect more than one of them. For example, a drug might be designed to block the reuptake of serotonin, but the drug will also block receptors for histamine because histamine structure is similar to serotonin, and therefore antihistamine side effects are common in many drugs that affect serotonin, and antihistamine side effects are things like sedation and dry mouth. Many antidepressants also block norepinephrine effects. This can lead to hypotension from alpha-1 blockade. And then acetylcholine is not a monoamine, but it is also a small molecule in the central nervous system, and there are a number of antidepressants that block muscarinic acetylcholine receptors, and these can cause tachycardia and urinary retention. The first group of antidepressants we'll discuss are the tricyclic antidepressants. These are very old drugs. They were some of the first antidepressants to come on the market in the 1970s and early 1980s. They're called tricyclic drugs because all of them have a chemical structure with 3 rings, as shown here for amitriptyline. And they work by blocking the reuptake of serotonin and norepinephrine. Their major downside is that they are what's known as broad-spectrum drugs. They have lots of effects on different receptor types. So they have antihistamine effects, antimuscarinic effects, they block alpha-1 receptors, and all of this leads to lots of side effects of these drugs. So these drugs came on the market in the 1970s and early 1980s, and when patients took them at that time, they had many of the side effects listed on this slide. So because of antihistamine effects, patients on tricyclic drugs often had sedation and weight gain, and patients could become confused, especially the elderly. Anticholinergic effects from blocking muscarinic receptors led to things like blurry vision and constipation. Dry mouth was a big problem. Patients taking these drugs would drink lots of water, and then that would give them a full bladder, but they had urinary retention because of anticholinergic effects. And then sexual dysfunction was also common. And because of alpha-1 blockade, these patients often developed postural dizziness and orthostatic hypotension. Tricyclic antidepressants can be classified into those that are tertiary amines and those that are secondary amines. Tertiary amine drugs include drugs like imipramine. They have a nitrogen group with 3 attachments, as you can see here. That's why they're called a tertiary amine. Secondary amines are drugs like nortriptyline. They have a nitrogen group with only 2 attachments. That's why they are called a secondary amine. So the tertiary amines included these drugs I've listed here, and their claim to fame was that they were more sedating. That's because they had more antihistamine effects. So these were used in patients who had trouble sleeping sometimes. The major secondary amines were desipramine and nortriptyline, and their claim to fame was that they were more activating from norepinephrine effects. So these were used in patients who were more sedated or who had psychomotor retardation to try and perk them up. Besides all the side effects, the major downside of tricyclic antidepressants was that they are potentially fatal in overdose, and they were being given to people who had depression and who were prone to suicidal ideation and suicide attempts. Tricyclic antidepressants can cause seizures and coma. That's because the drugs antagonize GABA receptors in the brain. GABA is an inhibitory neurotransmitter, so when you block GABA effects, you get overactivity of neurons in the brain, and that can lead to seizures. Because these drugs had anticholinergic properties, they could cause anticholinergic toxicity with all the signs and symptoms of an anticholinergic toxidrome. This included hyperthermia from loss of sweating. Because patients couldn't sweat, they couldn't dissipate heat from their face, so their skin would get flushed. The pupils would dilate from anticholinergic toxicity, and the GI tract would develop ileus, and there would be urinary retention. The alpha-1 blockade caused hypotension, and this was a major cause of death. And then lastly, these drugs can prolong the QT interval on the EKG, and that can lead to arrhythmias. So back in the day when many patients were prescribed tricyclic antidepressants, patients would come into the ICU with tricyclic antidepressant overdose. And when this happened, you would put them on the telemetry monitor and you would monitor the EKG for the QRS interval duration. And the reason you did this is because the most prominent manifestation of tricyclic toxicity is prolongation of the QRS interval. This happens because tricyclic drugs block cardiac sodium channels. And so patients who had evidence of a broadening of the QRS interval were at high risk for arrhythmias and death. The treatment that you would administer in the ICU was sodium bicarbonate. This helped for two reasons. First of all, the sodium in the sodium bicarbonate would help to overcome the sodium channel blockade of tricyclic antidepressant drugs. In addition, the bicarbonate would raise the pH, and this favors an inactive form of the drug, and therefore there are less tricyclic antidepressant effects. You won't see tricyclic antidepressants used to treat depression in the modern era, but these drugs do have a number of non-depression uses. Clomipramine is used in the treatment of obsessive-compulsive disorder in some cases. Amitriptyline and desipramine can improve nerve function, and so they are used in patients with diabetic peripheral neuropathy. A number of these drugs have some small benefit in patients with chronic pain syndromes, especially amitriptyline, but also these other ones listed here. And amitriptyline can also be used for the prevention of migraine headaches. In children who have bedwetting, which is called enuresis, the first-line therapy is desmopressin, but second-line options are a number of tricyclic antidepressants, including imipramine, amitriptyline, and desipramine. All of these drugs cause urinary retention as a side effect, and therefore if you give them to children who have bedwetting problems, they will hold their urine during the night. And then lastly, doxepin is one of the tertiary amine tricyclic drugs that causes sedation, so it is sometimes used for insomnia. Next class of antidepressants are the MAO inhibitors. These drugs inhibit the enzyme monoamine oxidase, which breaks down monoamines in the central nervous system. This includes neurotransmitters like serotonin, norepinephrine, and dopamine. They are all monoamines. There are two important MAO enzymes. MAO-A breaks down dopamine, serotonin, and norepinephrine, so inhibiting this enzyme is helpful to boost levels of these neurotransmitters in patients with depression. MAO-B breaks down only dopamine, and as we'll talk about in a minute, inhibiting MAO-B is sometimes helpful in patients who have Parkinson's disease with low levels of dopamine in the central nervous system. The so-called non-selective MAO inhibitors include drugs like tranylcypromine, phenelzine, and isocarboxazid. These drugs were used to treat depression. They inhibited both MAO-A and MAO-B and boosted levels of monoamines in the central nervous system. Selegiline is a drug that is MAO-B selective. This will only boost dopamine levels, and this is used in the treatment of Parkinson's, which I talk about in another video. And these drugs have really fallen out of favor. They're rarely used as antidepressants in the modern era because they have side effects and because other drugs like SSRIs and SNRIs are better tolerated. Places you will sometimes see them used in the modern era are refractory cases of depression and occasionally in anxiety. One of the major downsides of MAO inhibitor drugs is that they are associated with the serotonin syndrome, which is a potentially life-threatening syndrome that occurs when there's too much serotonin activity in the brain. The clinical features of the serotonin syndrome are often remembered by the mnemonic the 3 A's. The first A is for agitation, which refers to mental status changes. Patients with the serotonin syndrome can become agitated, restless, disoriented, and confused. The second A is for autonomic hyperactivity. These patients develop sweating, which is diaphoresis, their heart races, and they can develop a high body temperature, which is hyperthermia. And then the last A is for neuromuscular hyperactivity. So these patients develop a number of neuromuscular problems. They can have a tremor, they can develop clonus, their reflexes can be hyperactive, and you can also see bilateral Babinski signs. The treatment for the serotonin syndrome is a drug called cyproheptadine. It is a serotonin antagonist and can blunt many of these effects. So the serotonin syndrome usually doesn't result from just taking an MAO inhibitor. It usually happens when a patient who is already on an MAO inhibitor takes another drug with serotonin activity. And one of the reasons MAO inhibitors aren't that popular anymore is because there are lots of drugs with serotonin activity that you can't combine with an MAO inhibitor. So let's review what some of those other drugs are. So patients on an MAO inhibitor who take other antidepressants like SSRIs, SNRIs, or tricyclics can develop the serotonin syndrome. MDMA is an illicit drug. It's called ecstasy, and it works by boosting serotonin levels. So if you combine that with an MAO inhibitor, that can easily lead to the serotonin syndrome. Ondansetron is a drug for nausea. It blocks serotonin 5-HT3 receptors, and when you block those receptors, more serotonin goes to other serotonin receptors, and in a patient on an MAO inhibitor, that can lead to the serotonin syndrome. Tramadol is a weak opioid used to treat pain, and it inhibits serotonin reuptake. Meperidine is also an opioid that blocks serotonin reuptake. Triptan drugs are used to treat migraine. They are all serotonin agonists, so if you combine these with an MAO inhibitor, that can overload the brain with serotonin effects. Linezolid is an antibiotic that's a weak MAO inhibitor. Dextromethorphan is a cough suppressant that is a weak SSRI. And then lastly, St. John's wort is an herbal supplement that some patients take for depression. It works by increasing serotonin activity. So because of the risk of the serotonin syndrome, you have to be careful when switching from an MAO inhibitor to an SSRI or vice versa. If you're taking a patient off an MAO inhibitor and starting an SSRI, you wait 2 weeks to allow the MAO inhibitor to wash out before you start the SSRI. When you're switching from an SSRI to an MAO inhibitor, you also usually allow a 2-week washout. The one exception is the SSRI fluoxetine. You have to wait 5 weeks for that drug to wash out because it has a longer half-life. Besides the serotonin syndrome, another major downside of MAO inhibitors is that they interact with a naturally occurring substance called tyramine to potentially cause life-threatening hypertension. Tyramine is a naturally occurring monoamine. This is its structure shown on the screen. And it's a sympathomimetic, meaning it boosts activity of the sympathetic nervous system and causes sympathetic activation. Normally, tyramine is metabolized by the GI tract, but in patients on MAO inhibitors, tyramine gets into the bloodstream. And when this happens, it can diffuse throughout the body, activate the sympathetic nervous system, and potentially cause hypertensive crisis. This is referred to as the cheese effect because cheese, red wine, and some meats contain lots of tyramine. So back in the day when MAO inhibitors were used, if a patient on one of these drugs went out and had pizza and red wine, they would come into the emergency room with headache and a blood pressure in the 200s. That was a hypertensive crisis, and that was evidence of the cheese effect. SSRIs are selective serotonin reuptake inhibitors, and as their name implies, these drugs selectively inhibit 5-HT, which is serotonin, reuptake by neurons, and this leads to higher levels of serotonin in the synaptic cleft. The onset of these drugs is slow, over a few weeks, so after you start one of these medications, you have to wait several weeks before you can determine whether it's going to benefit the patient. And they're used in many psychiatric disorders, especially depression, but also in all these other disorders listed here, there is some evidence for the benefit of SSRIs, and I've listed the names of some of the most popular SSRIs on the screen here. Most patients who begin treatment with an SSRI experience nonspecific side effects that subside after they've been on the drug for a while. These are things like headache and insomnia, GI upset, or drowsiness. These things usually get better after a few weeks. There are some rare but potentially dangerous side effects that you have to look out for. One of these is hyponatremia from SIADH. In any patient with hyponatremia, one of the first things you want to do is check the medication list because lots of drugs cause hyponatremia, and SSRIs are one group of drugs that can do that. These drugs can prolong the QT interval, and I've unfortunately seen a few patients in my career who've had syncope from QT prolongation and arrhythmias on SSRIs. And then as we talked about earlier, these drugs can cause the serotonin syndrome, especially if they're given together with an MAO inhibitor. And then the last side effect, and one of the ones that most commonly leads to patients stopping these drugs, is sexual dysfunction. So SSRIs commonly cause sexual dysfunction by increasing serotonin levels in the spinal cord. The most common manifestation of this is decreased libido, which occurs in over half of patients. Another major problem is anorgasmia, which is difficulty achieving orgasm. This is reported by a third of patients, and then about a third of men report erectile dysfunction. Unfortunately, this side effect usually does not subside over time, and if it's a problem for the patient, then you have to try to modify the dose or sometimes try different agents because not all SSRIs affect each patient the same way. And then lastly, because these drugs delay orgasm and ejaculation, they can sometimes be used to treat premature ejaculation in men. If a patient has been on an antidepressant for a long time and you stop it abruptly, they can develop what's known as the discontinuation syndrome. This can happen with any antidepressant, but it's most common with SSRIs. The one exception is fluoxetine, which is famous for its long half-life, so the discontinuation syndrome is uncommon. Symptoms of the discontinuation syndrome are non-specific, but they include things like dizziness, fatigue, headache, and nausea. And to avoid this, anytime you're going to stop an SSRI or another antidepressant, you slowly taper off the drug. SNRIs are serotonin norepinephrine reuptake inhibitors. These drugs work like SSRIs in that they inhibit serotonin reuptake by neurons, but they also affect norepinephrine. Similarly to SSRIs, these drugs take 4 to 8 weeks to have effects on mood, and they're used in many psychiatric disorders. They're very popular for depression, but they're also used in all these other psychiatric disorders listed here. I've listed the names of some of the common SNRIs on the screen here. One of them is duloxetine, which has been shown to have some benefit in patients with fibromyalgia, and venlafaxine is sometimes used in patients with diabetic neuropathy. The side effects of SNRIs are similar to SSRIs. There's one exception. These drugs can increase the blood pressure, and that's because of the norepinephrine effects. And then these drugs also cause sexual dysfunction, and the highest rates have been associated with the SNRI venlafaxine. We'll finish this video by talking about some of the atypical antidepressants, and the first one we'll discuss is bupropion. Bupropion works by blocking the reuptake of norepinephrine and dopamine. It also increases the presynaptic release of catecholamines. It has no effects on serotonin. Because it boosts levels of norepinephrine and dopamine and catecholamines, it's a stimulatory antidepressant. Its two major uses are in depression and also smoking cessation. It's been shown to help people quit smoking. And one of the places in depression that it's very popular is using it in conjunction with an SSRI. Bupropion can improve the sexual dysfunction of SSRIs. So if you give it together with an SSRI, patients have better sexual function. The toxicity is related to its stimulant effects. It can cause anxiety or insomnia. And then it's also famous for lowering the threshold for seizures. On the modern formulations of this drug, seizures are very uncommon, but they can occur. Mirtazapine is an antidepressant with a couple of mechanisms of benefit. First of all, it blocks presynaptic alpha-2 receptors, and this causes more norepinephrine and serotonin release. We'll talk more about this in just a second. It also blocks two postsynaptic serotonin receptors, the 5-HT2 and 5-HT3 receptors, and when these are blocked, there will be more activity at 5-HT1, which is beneficial. Mirtazapine has lots of antihistamine side effects, especially sedation, and so it's sometimes administered to patients with depression who have trouble sleeping at night. Other antihistamine side effects can also occur, like dry mouth, increased appetite, and weight gain. This is the way that alpha-2 receptors work. They're found on presynaptic neurons, and when neurotransmitters are released into the synaptic cleft, they bind there to cause negative feedback. So if you block these alpha-2 receptors, there'll be no negative feedback, and the presynaptic neuron will keep releasing norepinephrine and serotonin. Trazodone and nefazodone are weak serotonin reuptake inhibitors. They also have specific effects on the serotonin 2A and 2C receptors. At lower doses, they are antagonists to these receptors. At higher dosages, they are agonists. These drugs can be used for depression. Trazodone is often used for insomnia. That's because it is a sedating antidepressant. Nefazodone is used in depression. One of its problems is it can cause liver failure, so you have to monitor the AST and ALT. And then it's super high yield to know for your boards that trazodone can cause priapism. Priapism is a persistent erection. It gets its name from Priapus, the Greek god of fertility, shown in this picture here. And the persistent erection of priapism can cause compartment syndrome and lead to hypoxia and acidosis in the cavernous tissue of the penis, and therefore it's potentially life-threatening. And it is a rare but dangerous side effect that has been associated with trazodone. It usually occurs within 1 month of starting treatment, and the management requires an urgent urology evaluation, and what the urologist needs to do is inject a vasoconstrictor into the intercavernosal space. This will constrict the cavernous smooth muscle and allow venous outflow from the penis. So the drugs that are used to do this are epinephrine and phenylephrine. And this is done urgently, often in the emergency room or the hospital, to try and prevent progression of the compartment syndrome. And that concludes our module on antidepressants.